Hola, buenas noches. Soy la doctora Mercedes Amieva, secretaria de Relaciones de esta mesa directiva. Bienvenidos a una sesión más de la Asociación Mexicana de Gastroenterología. Y como ustedes saben, este año hemos tratado de tener sesiones de muy alta calidad y el día de hoy no podía ser la excepción. Contamos con dos ponentes de alto nivel a nivel mundial. Y en esta ocasión vamos a hablar sobre enfermedad por reflujo gastroesofágico extraesofágico, si realmente es mito o realidad. Y en esta ocasión la sesión está en conjunto con la Asociación Mexicana de Neurogastroenterología y Motilidad. Para esto nos acompaña el doctor Enrique Coss. Él es ampliamente conocido por todos ustedes. Él es gastroenterólogo y neurogastroenterólogo por el Instituto Nacional de Ciencias Médicas. Actualmente es el jefe del servicio de motilidad en esa institución y actualmente es el presidente de la Asociación Mexicana de Neurogastroenterología y Motilidad. Bienvenido, Enrique.
Muchas gracias, Mercedes. Muchas gracias por la presentación y yo destacar también el gran esfuerzo y la gran labor de José María Remes al frente de esta mesa directiva, en donde ha traído esta calidad de webinars que sé que va a ser de gran utilidad para la práctica clínica de cada uno de nosotros. Y sin más preámbulo, me voy a permitir presentar a nuestros ponentes. Hoy tenemos una sesión muy interesante y va a estar con nosotros el doctor Prakash Gyawali. Prakash es un gran amigo de la Asociación Mexicana de Gastroenterología y de Neurogastroenterología. Es un experto en el rubro de la enfermedad por reflujo gastroesofágico y además es coautor de las consenso de San Diego en síntomas laringofaríngeos y enfermedad por reflujo laringofaringea. Y creo que esto da muchas más credenciales con todo su background acerca de esta situación. Y por último, también vamos a tener a seguir a un gran amigo también, Walter Chan. Es un experto también en enfermedades como en la enfermedad por reflujo gastroesofágico y ha hecho muchas investigaciones en trastornos extraesofágicos que ocasiona el reflujo. Y bueno, con ello es esta introducción. Primero, pediré al doctor Prakash Gyawali que nos hable de las manifestaciones, cómo hacer el diagnóstico de la enfermedad por reflujo gastroesofágico y manifestaciones estresofágicas. Walter tiene su base en San Luis, Missouri, y es el director de neurogastroenterología y motilidad en la Universidad de Washington, allí en San Luis. Y bueno, una autoridad. Y con ello, Walter, please, you can start your presentation. It's an honor to have you here. Very nice to have you, and go ahead, please.
Thank you very much, Enrique. It's a pleasure to be on this panel speaking to all of you about how to diagnose extraesophageal GERD. My gratitude, my thanks to the Mexican Association of Neurogastroenterology and Motility. And as Dr. Coss mentioned, I have had a long relationship and a very enjoyable relationship with the Mexican Neurogastroenterology and Motility Society. So it's a delight for me to be presenting today. So I'm going to talk about how to diagnose extraesophageal GERD. And we're going to start by talking about the fact that the terminology that we use to describe extraesophageal GERD in some ways has changed with the San Diego consensus. So instead of calling symptoms from the throat LPR, or laryngopharyngeal reflux, we're actually going to call them laryngopharyngeal symptoms, which is more appropriate because many of these do not have a direct link to gastroesophageal reflux disease. And these are some of the symptoms that are included under that category of laryngopharyngeal symptoms. They can be constant symptoms that the patients have all the time, or they can be episodic. They can have bursts or episodes or attacks of these symptoms and feel okay the rest of the time. And it's important to make that distinction between constant symptoms and episodic symptoms. Now, when there is evidence for reflux on testing, we will call the condition laryngopharyngeal reflux disease, which will account for a proportion of these patients, but the majority will not have reflux evidence, and therefore they will just have laryngopharyngeal symptoms, or LPS, and no LPRD. Now, you may wonder why I haven't included globus in this list. That's because globus is an interesting symptom. It is a constant symptom of tightness at the back of the throat. And it turns out that reflux is not one of the more likely causes of globus, even though they may coexist by chance alone. So in this Scandinavian population survey, 20% reported both symptoms, but only 50% of patients with heartburn had globus. Not everybody did. The Olmsted County population survey from many years ago showed that the odds ratio of patients with heartburn having globus is about 1.9, but there is no consistent relationship between isolated globus and abnormal acid exposure in controlled studies, and indeed, treatment of reflux with cimetidine or other anti-secretory medications does not improve globus. So globus and gastroesophageal reflux disease may be two separate entities. Now, a lot of these symptoms with patients with throat symptoms see our ENT colleagues first. And one of the tests that is employed by our ENT colleagues is to look in the larynx with the laryngoscope. And the issue is, a lot of times based on the findings reported by our ENT colleagues, some of these patients end up with reflux-like treatments and don't necessarily get better. Now, the problem is there is suboptimal inter-observer agreement among the various findings that are reported to be associated with reflux in the throat. So this is a very murky area, and the findings seen at the back of the throat on laryngoscopy is not thought to be consistent always with a reflux-based mechanism. Indeed, if you take findings from the reflux finding score, or the RFS, and use that to treat reflux, it turns out that the reflux finding score, or the laryngoscopic findings, do not change between before fundoplication, in this case, to after fundoplication. Indeed, laryngoscopic findings does not confirm reflux disease. But in a meta-analysis of 18 studies looking at laryngoscopic findings, there was a small signal for laryngeal cancer in patients with throat symptoms. So laryngoscopy is indicated in patients with throat symptoms, but not for decision-making for escalation of reflux management. Now, you may have heard about the San Diego consensus, which just got published. This is an algorithm for evaluation and management of patients with laryngopharyngeal symptoms. Obviously, at the outset, we want to consider non-GI causes for symptoms, especially when these throat symptoms are isolated. But laryngoscopy is not diagnostic of laryngopharyngeal reflux disease, but evaluates for non-reflux related causes of LPS. So the next steps in the evaluation relate to whether the patient has concurrent typical reflux symptoms in addition to extraesophageal laryngopharyngeal symptoms or not. And why is that relevant? Because isolated cough or isolated laryngopharyngeal symptoms don't normally respond very well to reflux-like treatments. These are data from randomized placebo-controlled studies. And if you look at the column to the right, the number needed to treat for a response for these throat symptoms are very high, in contrast to the number needed to treat for a response for patients with heartburn, where the number needed is just 2. Now, cough is a dichotomous situation where if you can confirm that there is a reflux-mediated mechanism for cough, the number needed to treat for a response to acid suppression is much lower than when reflux testing is negative. And that is something we have to keep in mind for cough. But if you look at all the studies that look at proton pump inhibitor trials, For episodic symptoms like cough, the value of proton pump inhibitors in improving symptoms, so giving us direction as to whether reflux is part of the pathophysiology, is not very good. And in patients with mixed symptoms, where there isn't an episodic symptom, there's a mixture of constant symptoms and episodic symptoms, the value is even less. Now, there are scores that have been devised to try and stratify the likelihood of reflux. And one of those is this cough reflux score that takes into account cough, the body weight, so BMI, globus, which actually is a negative point for globus, hiatus hernia, regurgitation, and male sex. And this was designed using a large training cohort, multi-center cohort, where conclusive GERD criteria were assessed similar to that recommended by the Lyon 2. And using statistical analysis, the 3 different groups of patients could be stratified using this: unlikely GERD, inconclusive GERD, and likely GERD. And in fact, these stratifications work well in determining likelihood of proven GERD. Indeed, in a validation study where the cough reflux score was used and patients were evaluated for evidence of conclusive GERD, the likelihood of finding advanced grade esophagitis or Barrett's esophagus was much higher in patients who were scored as having likely GERD. And these were indeed independent predictors for PPI response. So high cough reflux score of more than 5, the odds ratio for a PPI response was 15. Why is that? Because of the structure of the cough reflux score, where the unlikely GERD categories are isolated symptoms, isolated laryngopharyngeal symptoms, in this case cough, whereas the likely GERD groups have risk factors for typical GERD and likely have both the laryngopharyngeal symptom and a typical esophageal symptom. So it's important to look and determine if the patient that you're evaluating with throat symptoms indeed has typical reflux symptoms, because if they do, if they have typical esophageal reflux symptoms, then it may be worth using an empiric treatment trial in those patients, because at least the typical symptoms will get better. Indeed, that is what the Lyon consensus recommends. In typical symptoms without alarm features, an empiric trial of anti-secretory therapy and going on to evaluation, esophageal physiologic evaluation, only if that fails. Whereas in other atypical extraesophageal symptoms, you start out with upfront esophageal evaluation. You always have to consider other confounders like behavioral syndromes, rumination, supragastric belching, pulmonary symptoms, pulmonary syndromes, and throat syndromes. But if you look at this algorithm shown here, it all starts with endoscopy. And so it's important to think about endoscopy as a useful initial test, especially when there are concurrent typical symptoms. And according to the Lyon consensus, these findings on endoscopy, LA grades B, C, and D esophagitis, biopsy-proven Barrett's mucosa, peptic esophageal stricture, these are findings that are conclusive for reflux. So evaluation is done, the patient at least has distal reflux. It doesn't prove that the throat symptoms are from reflux or the extraesophageal symptoms are from reflux, but you have something to start treating the patient for, conclusive GERD in the distal esophagus. Now, when it comes to patients with laryngopharyngeal symptoms, who benefits from upper endoscopy? It turns out that both patients with isolated laryngopharyngeal symptoms and patients with laryngopharyngeal symptoms and typical symptoms have endoscopic or can have endoscopic findings that could impact management. But the likelihood of finding advanced grade esophagitis is much higher in patients with throat symptoms that also have typical symptoms. So that is something to keep in mind. If there are typical symptoms, we try to evaluate them like we do typical symptoms. Now, there is also the option of wireless pH monitoring during that same endoscopy session. If the patient is brought to the endoscopy suite off therapy, and that is how we recommend upper endoscopy be performed. Indeed, the diagnostic yield of wireless pH testing in this one study was higher than the yield of pH impedance monitoring performed. In this particular study, it is useful to note that a very small proportion of patients had both wireless pH monitoring and impedance pH monitoring, and the concordance of abnormal reflux-related findings in both tests was not as high as you would think. Indeed, there was a study about 10 years ago looking at the potential value of prolonged pH monitoring in patients with laryngopharyngeal symptoms. And this study had 66 patients, all of whom had both pH impedance and wireless pH monitoring of PPI. And 44% had discordant results. The findings in patients who had catheter-based testing negative Bravo positive, catheter-based testing positive Bravo negative and cath negative Bravo negative was similar. But the group we are going to focus in on are the patients who had pH impedance monitoring negative but Bravo positive. And you can see that in these patients, the wireless pH monitoring findings were dramatically different from the pH impedance studies. There were significantly higher reflux episodes and acid exposure time. And when they analyzed further and looked at the patients with these discordant findings, the discordance between pH impedance monitoring and wireless pH monitoring was highest in patients who had both laryngopharyngeal symptoms and typical symptoms, suggesting that catheter-based pH impedance may not be adequate in patients who have both typical and atypical findings. Now, if you look at pH impedance monitoring alone, the best data comes from pH impedance monitoring patients with episodic laryngopharyngeal symptoms like cough. So the value of looking at pH impedance in this setting is that you can look using the impedance parameters and sometimes with the combined manometry and impedance parameters to look at the physiologic signature for cough. And here you can see a cough episode triggered by acid reflux, but sometimes you can have reflux triggered by cough. And you can determine that relationship using the impedance-based monitoring, and in this case, combined with manometry to detect cough, the signal for cough. And the interesting thing was that the patients didn't register these coughs, so they did not punch their buttons in the pH impedance study when they had cough. Only 59% were registered. And you can see here the proportion of acid reflux triggering cough, impedance reflux triggered by triggering cough, but then also cough triggering acid reflux and cough triggering impedance-based reflux. And only about a fifth of patients had abnormal acid burden. The patients who had cough following an impedance-detected reflux episode had more cough bursts, more typical symptoms, more reflux episodes, and higher acid exposure time, suggesting that finding an impedance-based reflux episode moving high in the esophagus triggering cough may have some relevance when you're looking at evidence for reflux. So reflux episodes can trigger cough in about a quarter of patients. What are the features on pH impedance that determines a reflux etiology? This is another study from that same group that looked at 49 patients who are enriched. In other words, they had cough-related symptoms. And these investigators found that a higher proximal extent, longer reflux clearance time, higher acid burden in previous 15 minutes, and higher reflux burden on impedance previous 30 minutes were predictors for a relationship between reflux and cough, suggesting that in some patients, there can be a true reflux-induced cough. But the interesting thing is this did not relate to the nadir pH, the acid clearance time, or the degree of pH drop, suggesting that even in these patients with reflux-induced cough, there may be a hypersensitivity type mechanism. There was another group from Europe, from Italy, that showed that baseline impedance that was low in the proximal esophagus predicted PPI response in laryngopharyngeal symptoms, suggesting that if the reflux rate reaches the high esophagus and creates mucosal integrity issues, those are the patients who may improve. So the value of pH impedance is that it can potentially explain the mechanism of symptoms. On the other hand, the sensitivity of the test, the likelihood of finding a reflux link may be higher with wireless pH monitoring, especially in patients who have both typical and atypical symptoms. Now let's look at concordance of parameters in esophageal reflux monitoring. And here I'm going to compare this concordance between typical symptoms and throat-related symptoms. So you can see acid exposure time, symptom association probability. GPE is another way of looking at symptom association probability, SI symptom index. And positive means all metrics positive, negative means all metrics negative. So high quality evidence for reflux-related symptom would be when the patient has abnormal acid burden and also has reflux symptom association. You can see how low that number is for cough. And high quality evidence against reflux was much higher in this setting of cough. And obviously there were some patients who only had reflux symptom association. When it comes other ENT symptoms, constant symptoms, the numbers were small, but again, you can see that the trend is similar. What this tells us is that pathologic acid reflux and high quality symptom correlation are infrequent in laryngopharyngeal symptoms, and reflux symptoms correlation obviously is only possible for episodic, not for constant symptoms. So where do we fit in ambulatory reflux monitoring? It's in patients with unproven GERD, patients who have endoscopy negative findings, and the intent is to determine if GERD exists. And obviously the two options, the idea is to identify or rule out GERD. And in most patients with extraesophageal symptoms, we are ruling out rather than diagnosing GERD. It is relevant to find patients who truly have significant reflux that leads to refluxate aspiration and airway inflammation causing laryngopharyngeal symptoms and pulmonary symptoms. And this is where pH impedance may provide us the mechanism for these symptoms by looking at the proximal esophageal reflux migration. The other pathway is a reflex mechanism where small amounts, sometimes physiologic amounts of distal esophageal reflux exposure can create symptoms from a vasovagal reflex that is influenced by central pathways. In those patients, the upper esophageal sphincter barrier is intact and there is no pharyngeal refluxate. At the end organ level, with the reflux mechanisms, there is possibility for airway or end organ dysfunction, whereas with the reflex mechanisms, the airway and the lungs are completely fine. So let's summarize how we are going to use these diagnostic tests in patients with laryngopharyngeal symptoms and indeed other extraesophageal symptoms. Laryngoscopy, the value is to rule out cancer and other mechanisms of reflux. There is no conclusive finding that establishes reflux or rules out reflux. Upper endoscopy, we use Lyon criteria to identify reflux-related changes, but it can be normal in both GERD and extraesophageal symptoms. The shortcoming is that even if we find distal esophageal acid damage, that doesn't mean that the throat symptom is from reflux. 24-hour impedance pH monitoring obviously measures reflux burden, can provide acidic and non-acidic reflux numbers. There are criteria that rule out reflux, both off PPI and on PPI. But the issue is this is a 24-hour test. There can be day-to-day variability in reflux, and therefore it doesn't prove that there is absence of reflux if the test is normal. And reflux symptom association is suboptimal. Patients hate the catheter. Manometry diagnoses actionable motor disorders, but really does not confirm or rule out GERD in any way, although finding of ineffective esophageal motility may distract. It doesn't help with the diagnosis, but may distract. And wireless pH monitoring provides only distal metrics, even though it overcomes day-to-day variation in reflux burden. So use laryngoscopy to rule out cancer, use endoscopy to look for distal GERD evidence that can determine need for PPI. Use impedance pH monitoring for looking for mechanisms for LPS and to confirm LPRD. Use manometry to rule out confounding actionable motor disorders, and use prolonged pH monitoring in patients who have both typical and atypical symptoms to look for evidence of distal esophageal acid burden. So if you go back to the San Diego consensus, you can use the personalized lifestyle and peer treatment trials to decide who needs objective testing. Obviously, patients with no response need objective esophageal testing. But some patients may respond both from an esophageal symptom perspective and the LPS. Others may have isolated esophageal symptom response. And the implications are different, but even in these patients, if further escalation of management is considered, those patients may benefit from objective esophageal testing. Now, the patients with isolated LPS tend not to have reflux disease. They tend to more likely have some hypervigilance or hyperresponsiveness mechanism. So in those patients, it is worthwhile testing prior to any anti-reflux therapy, so upfront testing. Now, remember we said globus was different? The issue with globus is the likelihood of finding reflux is low. And so the algorithm for globus goes through doing all these different tests to look for an alternate mechanism. Right, so PPI response is very low. Manometry, sometimes major motor disorders, patients with achalasia outflow obstruction can have a throat sensation, a throat symptom. Reflux monitoring is mostly to rule out reflux, and most of the time management is with reassurance, neuromodulators, and complementary therapy. Other extraesophageal manifestations include the belching syndromes, and these are all behavioral. You can diagnose them with pH impedance monitoring. Here you can see the typical impedance signature of air, which is a rise in impedance, in this case, moving antegrade directly into the esophagus, then coming right out. That's the typical impedance signature of supragastric belching. You can also diagnose this with manometry. Here you can see diaphragmatic contraction with UES relaxation, an inward movement of air with immediate retrograde movement out. And sometimes this can be in the same patient with rumination, where rumination looks like a reflux episode. So some of these behavioral syndromes can overlap with reflux disease. You can diagnose rumination on postprandial monitoring with impedance. Here you can see the R wave rumination and the very high movement of gastric content into the throat. So using these tests, you can diagnose behavioral disorders. But it's important to remember that the hypersensitivity and hypervigilance that comes with what we traditionally think as functional or behavioral disorders can permeate across all these different phenotypes. In this case, using the esophageal hypersensitivity and symptom-specific anxiety score, or EHAS. You can see that EHAS scores are high, regardless of whether the patient has laryngopharyngeal symptoms with GERD, isolated laryngopharyngeal symptoms, or traditional GERD, and all of those were higher than controls. In another study, in patients with laryngopharyngeal symptoms, the value was similar whether the laryngopharyngeal reflux disease, so conclusive disease, was identified or not. And now there is a new score that is designed specifically for the larynx called the LCAT, or laryngeal cognitive affective tool, that is going to provide more specific hypersensitivity and hypervigilance information pertaining to the throat. And these can be useful in determining who has hypersensitivity. And finally, looking at the phenotypes is very useful. And this was a very smart study done by Dr. Chan and colleagues a few years ago. And this was a very nice way of using principal component analysis in 302 patients. And they were able to find 5 clusters of these patients with laryngopharyngeal symptoms, patients with both diseases, LPRD and GERD. And you can see the characteristics here. Patients with LPRD and mild GERD, a lesser version. And here you can see patients with other phenotypes that are more isolated symptoms in nature without GERD or with other other disorders. And if you look at the proportions here, they break down very nicely into a third having laryngopharyngeal symptoms and typical symptoms, and 2/3 with isolated laryngopharyngeal symptoms. The third with combined symptoms have dominant reflux, and the remainder, the 2/3 with isolated symptoms, likely have a hypervigilance mechanism. And that is what drives how we approach these patients. Everybody gets laryngoscopy. PPI and alginates are more likely to help patients with dominant reflux-mediated throat symptoms. Endoscopy findings in about 1/3 with dominant reflux is likely going to be normal in patients with hypervigilance and hypersensitivity. Wireless pH is used to rule out reflux in the patients with isolated symptoms, rule in reflux with dominant reflux. But pH impedance may help explain the mechanism of symptoms, not just diagnose reflux, but explain the mechanism of symptoms and find the patients who have very high proximal migration reflux rate in patients with dominant reflux. Manometry unlikely to explain symptoms, and questionnaires will quantify hypervigilance and anxiety in both these categories where it may permeate both conditions. And with that, I'm going to finish. Thank you very much for your attention, and I'll be very happy to answer questions at the end. Thank you.
Thank you very much, Prakash. Excellent lecture. Very, very interesting. So we are going to have a room for questions at the end. But now it's my pleasure to introduce Walter Shan. Walter, also a very good friend, an expert on the field. He is going to tell us about the treatment of these extraesophageal disorders. So Walter, please go ahead and share your presentation.
Thank you very much, Enrique, for the introduction and for having me tonight. I'm very happy to be here. I'm going to talk a little bit about the treatment of these extraesophageal manifestations or symptoms, kind of continuing on what Prakash was just talking about. I think one of the most important things when we approach these patients is, are we really looking at patients with reflux? We know that these type of laryngeal symptoms very common in the U.S. About 20% of the adult population experience these, and many of them are given this diagnosis that we just heard. And but we know that many of these patients actually don't really have reflux as the driver to their symptoms, and there are many different causes to these throat symptoms. So really finding the target to treat and make sure that we're treating reflux or other etiologies is important in managing these symptoms. One of the main questions is, well, can we just base treatment on symptoms alone? It turns out that we found that these type of laryngopharyngeal symptoms are quite poorly specific and are suboptimal predictors of true laryngopharyngeal reflux disease. And even other symptom metrics that have been developed for GERD or symptom patient-reported outcome measures that are developed for voice or cough symptoms are not really specific enough for diagnosing LPRD either. They might be useful when you want to follow their symptoms, but you can't really use these symptoms or symptom scores alone to help direct treatment to determine if they have reflux and you want to treat them. So how should we really approach and manage these patients? I know if you think about patients with typical reflux symptoms, usually we would start with, if the patients come in with symptoms that are suggestive of reflux, we'll put them on lifestyle modification, maybe make them change their diet, and then we'll do a trial of acid suppression, followed by an upper endoscopy, objective reflux testing, and maybe consider escalation of therapy if they still have symptoms. Well, can we follow the same paradigm for extraesophageal reflux? We just heard from Prakash that a lot of these patients, we want to have objective testing to confirm their reflux before we actually treat them. And there have been studies looking at empirically treating them with acid suppression therapy, like a PPI trial. And we also just heard that the response of these laryngopharyngeal symptoms in general, if we just put everyone on an empiric PPI trial, the response is quite suboptimal. Previous meta-analysis showed that there's only really marginal benefit with PPI, and usually only with specific symptoms. And there have been a recent randomized controlled trial comparing lansoprazole twice daily versus placebo, a very well-conducted trial in patients with chronic cough primarily, and also other throat symptoms, and show no difference in their outcomes. So maybe empirically putting patients on a PPI treatment is not really an effective strategy for treating the laryngopharyngeal symptoms. What do we know about, I mean, are we saying that we can't put these patients in a PPI trial at all, or are there specific patients that this might be more useful in? It turned out that the efficacy of PPI for laryngopharyngeal symptoms, even though they're suboptimal for in general, if you can prove that they have objective reflux, the treatment efficacy is better. So here you look at the number needed to treat in patients with chronic cough or reflux laryngitis symptoms. In patients without objective signs of reflux, you have a quite high number needed to treat. But among patients with objectively proven reflux, the number needed to treat approached that of typical reflux symptoms. So it went from like 25 or higher down to about 4. And patients who have laryngopharyngeal symptoms, who have concurrent esophageal symptoms, may represent a different phenotype. Maybe these patients have a higher pretest probability for reflux. So maybe this is a phenotype of patient with laryngopharyngeal symptoms who might be more likely to benefit from a PPI trial. So perhaps in patients with both laryngopharyngeal symptoms and esophageal symptoms, an empiric PPI trial, as well as dietary and lifestyle modification would be appropriate, given that they have higher likelihood of having true reflux. What about those patients with isolated LPS, isolated laryngopharyngeal symptoms? It turns out that in uninvestigated, basically unproven isolated LPS, there really is no benefit by PPI over placebo in randomized controlled trials. But when these same patients who have objective signs of reflux, again, we see that the number needed to treat really goes down, and there is a benefit if you can really prove that they have reflux. So perhaps this is the group of patients with isolated LPS who will benefit from testing first instead of just putting them on a PPI. And if you have objective signs of reflux, then you can treat them with medical reflux therapy or lifestyle modification targeting their reflux. So going back to the algorithm that Prakash just showed in terms of in the San Diego consensus, really one of the big divergent point is whether or not there's concomitant esophageal symptoms along with the laryngopharyngeal symptoms. And personalized lifestyle modification and also empiric acid suppression treatment trials are usually reserved for those with laryngopharyngeal symptoms who also have esophageal symptoms, or if you have objective testing showing that you have reflux, then doing reflux targeted treatment with lifestyle modification and PPI therapy would be useful. So what are some of these lifestyle modifications? These are very similar to what we do for patients with typical reflux, reducing intragastric pressure, maybe by weight loss, maybe avoiding tight-fitting clothing, minimizing postprandial reflux, so maintaining upright posture for at least a couple hours after eating. Perhaps diaphragmatic breathing can help with postprandial reflux as well. Modifying sleep position, especially in patients who have a lot of nocturnal reflux, so elevating the head of bed, also sleeping on the left side has been shown to help reduce reflux, as well as avoiding triggering foods. A lot of the spicy, sour food, caffeine, peppermint, those are some of the food that often trigger reflux. And other treatment modality that have been shown to possibly be useful in these patients is alginate therapy. So what is alginate? Alginate is actually a natural polysaccharide polymers that forms a gel when it comes into contact with gastric acid. So what happens is that when patients take this alginate, it basically forms a gel raft that will sit on top of the acid pocket that serves as a barrier to help reduce reflux from coming up. And there have been studies looking at patients with laryngopharyngeal symptoms where they try to add alginate to a PPI trial. And what they found was, a study has found that if you have patients take alginate 4 times daily, usually after meals and before bedtime, in addition to the PPI therapy, there's an increase in benefit for the laryngopharyngeal symptoms compared to just PPI monotherapy alone. So when you're trying to treat target reflux with medical therapy in these patients, consider adding alginate therapy to just PPI therapy alone. What about anti-reflux interventions, things like anti-reflux surgery, or now we have a lot of endoscopic therapy for reflux? Are these useful as well? For a very small percentage of patients, escalating anti-reflux therapy to a procedure like surgery may help improve LPS if these patients are very carefully selected with clear objective evidence of abnormal reflux on objective testing. And there have been studies that have shown that among patients with PPI refractory laryngopharyngeal symptoms who underwent anti-reflux surgery based on just laryngoscopic findings alone, not based on any objective testing for reflux, there is no improvement in symptoms or even the laryngoscopy findings after the anti-reflux surgery. But in another study where anti-reflux surgery or endoscopic anti-reflux therapy in patients with objectively identified reflux, there's significant improvement in their symptoms and quality of life after the procedure among these patients who demonstrated clear evidence of reflux on objective testing. So the lesson here is that if you're thinking about escalating therapy to either surgery or an endoscopic intervention, it really should be directed by objective evidence of reflux and should be very carefully selected. Now, in terms of targeting reflux with anti-reflux therapy, there's a population that I really want to highlight. Going back to these two mechanisms for extraesophageal manifestation of reflux that Prakash talked about, there's a group of patients, the group that have symptoms coming from reflux mechanism that might have more significant airway damage, patients with pulmonary symptoms or these end organ damage specifically in the lungs. So a lot of these patients who might have reflux-related chronic lung diseases or patient with lung transplantation, where reflux may actually damage their transplanted lung graft. In this group of patients, targeting and treating reflux might be even more important to help reduce these end organ damage. And having a lot of study on this, and I really want to highlight these patients who may have reflux-related pulmonary manifestations, because this is really a group of patients where it's not really just symptoms. I mean, you can really improve not just their quality of life, but their life expectancy if you can help improve their lung disease by treating their reflux. And there have been studies looking at patients both with chronic lung diseases and patients who have lung transplantation, where if you can employ timely anti-reflux therapy in patients who have evidence of reflux, it really improved their clinical outcomes for their lung disease and their lung transplant. So you can see here, there's a few studies we did looking at lung transplantations, patients who have undergone lung transplantation, and among patients who have a significant amount of reflux or negative reflux on objective testing, you can see that those who have reflux who don't get timely anti-reflux treatment tend to be much more likely to develop acute rejection or chronic rejection of the lung graft. But when you look at patients who have reflux, where you employ timely anti-reflux therapy, the outcomes significantly improve and approach those patients who have no reflux. So the lesson here is that routine reflux testing of these lung disease patients or lung transplantation patients may help guide timely medical or surgical GERD management to help optimize outcomes using some of the strategies we talk about, medical anti-reflux therapy like PPI, and even surgery to help improve their outcomes. We talk about treating reflux for laryngopharyngeal symptoms, but we also know that there are many other causes of these laryngopharyngeal symptoms. For example, oropharyngeal airway pathology or vocal cord dysfunction. Sometimes patients might have throat symptoms related to underlying lung diseases. Sometimes diet or medication may cause these throat symptoms like ACE inhibitors. Allergies or sinus conditions may sometimes lead to these symptoms. Also, alterations in brain-larynx interaction, so basically hypersensitivity in the throat or a neuropathic process or even psychological comorbidities can really contribute to these laryngopharyngeal symptoms as well. So maybe in addition to targeting reflux treatment, as a treatment modality, we should really think about all these other causes in treating the patient's symptoms and maybe targeting these other potential causes as well. The one that I want to highlight is the alterations in brain larynx interactions, because there's been increasing data recently that show that this might be a significant cause of patient symptoms. So what are some of these disturbances? There have been some studies that have shown that basically patients who have laryngopharyngeal symptoms in addition to reflux are more likely to have psychological distress and functional GI disturbances, including depression, anxiety, and sleep disturbances, compared to patients who have no laryngopharyngeal symptoms. There have also been studies that have shown that this esophageal hypervigilance and symptom-specific anxiety are much more common among patients with laryngopharyngeal symptoms compared to those without. So it seems like this brain larynx disturbance and hypersensitivity is important among patients with these laryngopharyngeal symptoms. And there have also been studies that have shown that with this higher level of anxiety and symptom-specific hypervigilance, they are quite similar between patients with and without reflux. So patients who have laryngopharyngeal symptoms, who have high level of anxiety or symptom-specific hypervigilance, it doesn't matter if they're reflux, they're more likely to experience this. So brain laryngeal or laryngeal neuropathic disturbances likely play an important role in the development and severity of LPS, really independent of reflux. And maybe this brain larynx disturbance is a potential target for therapy to help improve patient symptoms. So how does this actually work in this with this brain larynx disturbance? How does it actually cause LPS? Well, you can think of a model where it's sort of a vicious cycle. You may have some local irritant. It could be GERD, it could be other things that irritate the throat. In patients who have hypervigilance, it might cause some sort of laryngeal hyperresponsiveness. So people start swallowing more because they're irritated, or they breathe differently, or they try to clear their throat. And they're also very anxious, and they're very aware of the symptoms, which may also lead to laryngeal hypersensitivity. And because they're feeling their symptoms more, then they increase their hyperresponsiveness in terms of straining their vocal cord or swallowing or throat clearing, which then basically create a vicious cycle and keep worsening their symptoms. So the idea of treatment focusing on this brain larynx disturbance is really to break this cycle. So who are the patients that you can think about where this is needed? Well, perhaps in patients with isolated LPS who have no esophageal symptoms, or patients who have LPS and esophageal symptoms who underwent an empiric trial of acid suppression therapy, but are only getting partial improvement or no improvement in the throat symptoms, or patients who underwent objective testing and had a negative testing. And these are the patients you might have to think about a potential role of these laryngeal hyperresponsiveness or hypervigilance. And these are the patients that may benefit from therapy targeting this axis. And what are some of the therapy that you can consider? One is this laryngeal recalibration therapy. It is basically a novel spin on traditional voice therapy techniques. It combines usual voice therapy that are done by speech-language pathologists, plus autonomic regulation, so regulating some of these anxiety-induced autonomic symptoms like increased heart rate or disordered breathing. Also including cognitive reframing, so basically guiding patients in thinking about the symptoms. Basically, you want to address perceived and confirmed irritations manifesting at these throat symptoms. And the goal is to reduce these hyperresponsive behaviors, restore the patient's voice function, regulate their breathing, and also decrease their cognitive burden so they're less worried about the symptoms. And this combination of laryngeal recalibration therapy has been shown to be useful in a cohort of 65 patients, showing that the symptom improved in about 85% of them. And this improvement rate is similar between those with and without typical esophageal symptoms of reflux, and those with and without proven reflux. So perhaps this laryngeal recalibration therapy is useful for all patients with laryngopharyngeal symptoms. Cognitive behavioral therapy may also be useful. These are patients where anxiety and depression and other central processes may be playing a big part in the symptoms. There are really four main processes that you want to target. Cognition, these patients might think about these symptoms a lot. They really think that something is wrong, which may trigger fearful sadness and frustration in their emotions, which can then also lead to things like physiologic sensation changes, like they might feel tightening in their chest, they might get a higher heartbeat because they're anxious, and which lead to behavioral changes because then they start avoiding social activities or increasing healthcare use. So you might want to employ different techniques like, restructuring the cognitive thinking, helping them think about the symptoms in a different way, coping with their emotions related to the symptoms, maybe teaching them relaxation strategies, and maybe even conditioning them to these irritants or triggers by exposure therapy. So the combination of these cognitive behavioral therapy might be helpful in these patients' symptoms as well. Neuromodulation is another modality. You can consider using them in patient laryngeal hypersensitivity or patients with suboptimal medical reflex therapy response, or patients with isolated LPS. Basically, you want to reduce the sensitivity to symptoms. One of the main neuromodulator that's been studied is gabapentin. In a study of 62 chronic cough patients who are randomized to gabapentin versus placebo, it's been shown that patients who are on gabapentin had a significant improvement in their cough-specific quality of life compared to placebo. So gabapentin may be useful in these patients with chronic cough. A close cousin to gabapentin, which is pregabalin, had also been shown to be effective for these laryngopharyngeal symptoms as well. And these agents are useful either as monotherapy or even as an adjunctive therapy to other treatment like laryngeal recalibration therapy or other behavioral therapy. Tricyclic antidepressant is a common medication we use a lot for functional GI conditions or disorder with gut-brain interactions. For laryngeal symptoms, it's also been shown to be useful. It's been shown to result in significant improvement in cough-specific quality of life in patients with chronic cough. And the efficacy is quite similar to gabapentin. The only thing is that there seems to be a higher rate of discontinuation with TCA, perhaps relating to the anticholinergic effects of the drug, because it can cause a lot of dry mouth and dry throat, which may in turn exacerbate the laryngopharyngeal symptoms. Other neuromodulator may also be considered like SSRI and SNRI. The only thing is that there's not a whole lot of data with these yet, but in patients with a lot of anxiety and depression, these might be good options. The thing to remember is that most of the clinical data on these neuromodulators are coming from studies of unexplained chronic cough. So how much it improves other LPS is not well defined, but it is, an option to think about when you treat patients that you think might have brain larynx disturbances. Again, the most common side effects are anticholinergic effects. Some patients might develop drowsiness or fatigue with some of these medications as well. And you can really combine neuromodulator therapy with other treatment as well, including LRT, cognitive behavioral therapy, or even patients on anti-reflux therapy. So, to summarize all these treatment options, we have to think about what may be causing patients' laryngopharyngeal symptoms. Obviously, a patient with objective evidence of reflux, anti-reflux therapy would help. Patients with no objective evidence of reflux, you might have to think about managing other causes or airway causes of their symptoms. But remember that psychological factors and disturbances in brain larynx interaction can influence symptoms perception regardless of whether or not reflux is present. So behavioral therapy, neuromodulation can be useful in all patients with LPS. And you also have to think about other management strategies like avoiding trigger medications, think about allergy evaluations, perhaps anti-reflux diet, or even oropharyngeal swallowing assessment to rule out oropharyngeal dysphagia as a cause of their symptoms as well. So that's a quick overview of all the treatment strategies. I'm happy to take any questions.
Thank you so much, Walter, for this very clear and meaningful lecture. I think is very, very important, all the points that you have reached. But now I'm going to switch for Spanish. I'm going to do the questions and answers in Spanish so you can hear the translator for their understanding. Pues muchas gracias a todos que nos están escuchando y viendo. Y bueno, pues ahí tenemos varias preguntas que se han ido acumulando a lo largo de la sesión. Bueno, nos están viendo de México, pero también de otras partes de Centro y Sudamérica. Agradecemos a la doctora Cecilia Iriarte de La Paz, Bolivia, que nos haya hecho esta siguiente pregunta y probablemente dirigida de manera directa a Prakash, eh, en, en el sentido de cuál es el significado del reflujo no ácido para la generación de síntomas extraesofágicos, Prakash. Es decir, con el Bravo, que hay mayor evidencia, solo hay mucho, el contenido o lo que se ve es el reflujo ácido, pero ¿qué hay del reflujo no ácido?
So I think you're bringing up a very important point here. There are two ways to think about this. First, when you're doing physiologic testing, what are you trying to do, right? If you're trying to understand the mechanism of symptoms, in other words, you're trying to figure out why somebody is having throat symptoms, then looking at the entire spectrum of acid, non-acid, how high is the reflux rate going, where else is it triggering symptoms, the back of the throat, the larynx, that is relevant. That's the reason why pH impedance may be relevant in that setting. And you may be able to explain why somebody may have symptoms. When thinking about non-acid reflux, it is important to consider when does refluxate from the stomach have low or a low acid or higher pH. And usually that happens in the postprandial period when the gastric contents are neutralized by food. And indeed, that is also a prime time for reflux to happen. And so it may be very relevant in these patients with throat symptoms who have very high migration of refluxate. So I don't necessarily just look at the non-acidic reflux, but look at the total volume of reflux, the total number of refluxates that go high in the neck, and trying to explain laryngopharyngeal symptoms. There is another mechanism by which you can do that, and that is to look at the baseline impedance in the proximal esophagus. And indeed, there are new data coming out, including the Italian data and data from Dr. Chan's group, showing that lower baseline impedance, which is a consequence of all kinds of refluxates in the higher neck, kind of predicting that treatment with acid suppressants could be helpful in these patients, treating with alginates. Now, a quick word about wireless. Where does wireless come in? Wireless comes in when you are trying to quantify how much acid is there in the distal esophagus. And why do we want to do that? Because most of our data on escalation of therapy for reflux, escalation beyond just prescription of a medication, comes from documenting abnormal refluxate in the distal esophagus. And that value is highest in patients who have throat symptoms plus esophageal symptoms, because those are the ones who are most likely to have a reflux mechanism. And if you're thinking about escalating management beyond just acid suppression to anti-reflux surgery, fundoplication, that's where wireless may have highest value. But your question is spot on. Non-acid as well as acidic refluxates documented on pH impedance monitoring may help explain throat symptoms better than the wireless modality can.
If I can add really quickly, I think the one population where it might be even more relevant, we briefly touch on those patients with end organ damage, like those patients with lung diseases, lung transplantation, because you really are thinking about volume reflux that might damage the lungs. And that might be a little more, even more relevant in that population. There have been a number of studies we've done that have shown that volume total reflux predicts end organ damage more so than just acid reflux alone. So that might be a population you have to think about non-acid reflux.
Muchas gracias. Muy buena respuesta. Y ahora, Walter, ¿cuál es el significado o el papel del parche de mucosa gástrica ectópica, el gastric inlet patch, para la generación de síntomas? Y si hay un tratamiento, eso lo pregunta Jorge Aquino Matus.
Yeah, that's a really good question. So we're seeing these, especially we really carefully look for these. There have been a number of studies that have shown that the presence of these ectopic gastric mucosa actually is associated with more severe laryngopharyngeal symptoms. And so it is possible, because these are actually acid secreting functioning gastric mucosa, that it might be linked to some of these laryngopharyngeal symptoms. There have been some case series that have been published that have shown that if you do radiofrequency ablation of these ectopic mucosa, it might help reduce these patients' laryngopharyngeal symptoms. So it might be something to consider, but I will caution that these are all case series. These are not controlled trials, and the outcome is symptom improvement. So it's really hard to say how much of it is a placebo effect versus a true effect of the radiofrequency ablation. I know there's some controlled trial that are ongoing right now, so hopefully we'll get more data on that. But in patients with refractory symptoms, you can clearly see an ectopic mucosa. It can be considered, but it's really based on very low quality evidence at this point.
Gracias, Walter. Nos pregunta la doctora María Eugenia Casa. Creo que, bueno, esta ustedes pueden decidir quién de los dos quiere responderla. Y es, ¿qué hay acerca del roncar? Ya nos hablaron de algunos problemas pulmonares que pueden ocasionar problemas laringofaríngeos, pero ¿qué hay del roncar, de la apnea obstructiva del sueño? Walter.
Yeah, I'm happy to. Yeah, there have been actually quite a few studies over the years that have shown that obstructive sleep apnea is associated with more reflux. Now, not specifically just laryngopharyngeal reflux disease, but overall GERD, due to the changes in physiology. And treating obstructive sleep apnea might help alleviate some of these symptoms. But the main thing is, a lot of these patients, the underlying cause of the obstructive sleep apnea might be obesity, and we know that that might be one of the main triggers and causes of reflux. So perhaps that will be a target, in addition to treating just the OSA, but treating some of these underlying causes. But it certainly can be related to reflux.
And I would add to that there probably has to be an EGJ mechanism that promotes reflux in these patients for reflux to become a serious issue. There is also increasing CPAP and things like that doesn't necessarily make them feel better. Doesn't necessarily. So it's a complex issue that isn't simply managed. The one thing that does seem to help all of these is weight loss. Weight loss seems to help. It'll help snoring too, but it can help reduce reflux and reduce the need for CPAP.
Bien, y Prakash, ¿ves un lugar en el tratamiento de estas entidades con los PCAPs? Eso lo pregunta el doctor Carlos Asensio de Guatemala.
So the short answer is probably yes. And but I think you have the same issues with PCAB that you have with PPIs, which is, if the issue is acid related, then suppressing acid will help. So again, if the issue is acid related, suppressing acid will help. Now, will empiric use of PCABs have better value than empiric use of PPIs? Maybe, but for typical symptoms, that has not been demonstrated thus far. So when people have tried to study the PCAB trial for heartburn and regurgitation, it has not performed better than the PPI trial for heartburn and regurgitation. So the benefit may be in patients who have lesser degrees of reflux triggering a lot more of esophageal hypervigilance and hypersensitivity. We're neutralizing even, low acid burdens or even physiologic acid burdens could be of value, but these studies need to be performed. I think there is very limited anecdotal data for the use of PCABs in laryngopharyngeal extraesophageal symptoms, and not all of what's out there is positive.
Muchas gracias. Y bueno, de nueva cuenta, agradecer al doctor Prakash Gyawali de la Universidad de San Luis, de la Universidad de Washington en San Luis, Missouri, al doctor Walter Shan, jefe de motilidad y neurogastroenterología en el Brigham and Women's Hospital. Ha sido una maravilla de sesión tenerlos a los dos y bueno, agradecerles su presencia y su tiempo para estar con nosotros. Y voy a dar paso a la doctora Mercedes Amieva para que despida esta sesión.
Muchas gracias, Enrique. Muchas gracias a nuestros ponentes. Igual queremos decirles que ellos nos van a acompañar en Semana Nacional de Gastroenterología en Veracruz. Vamos a tener diferentes ponencias y están todos invitados. Y ahora, si me pasan la siguiente cortinilla, los quiero invitar a nuestra próxima sesión el próximo mes, en la cual vamos a estar hablando sobre el tratamiento personalizado de la fibrosis hepática. En esta ocasión nos va a acompañar el doctor José Antonio Velarde Ruiz Velasco, que es hepatólogo, igual que la doctora Eida Cerda, y tenemos como invitado especial al doctor Jordi Gracias Sancho, que es especialista en el tema. Los esperamos todos y buenas noches.